Great. So welcome everyone. Thank you for joining NAMI Greater Cleveland today for this program on understanding treatment-resistant depression, diagnosis, and strategies for support. Very happy to be joined by Abby Herrold, who is a postdoctoral fellow at MetroHealth here in Cleveland. Please note a few things before we get started. Many of you have likely attended many of these webinars before, so some of this may sound familiar. Please do remember that this is being recorded. We will share these slides from the PowerPoint with you in a follow-up email after the webinar concludes by 1 p.m. We'll also upload the recording of this webinar to our YouTube channel so you can view it at a later date. Please also note that this webinar is eligible for one CEU, one unit of continuing education for counselors and social workers and marriage and family therapists. We have we've updated our evaluation system, and now we have one single evaluation. So whether you are attending this webinar for general educational purposes or for CEUs, you'll complete one evaluation. I will provide that link in the chat when we wrap up. Please do remember to provide your name, email address, license type, and license number in that survey. It's the very last question in order to receive CEUs for today's webinar. Please also remember to remain muted throughout the webinar unless you're speaking. Want to eliminate any peripheral background noise. Please also utilize the chat feature if you have questions. I will be monitoring the chat. However, we will also allocate around 10 minutes before we wrap up by 1 o'clock for additional Q&A as well. And you must attend the webinar in its entirety in order to receive that CEU as well, okay? And otherwise, just know that NAMI Greater Cleveland is a resource for you here in Cuyahoga County. Our mission is dedicated to improving quality of life for individuals living with mental illness and their family members through providing our support groups, our helpline services, and educational programs like today's webinar. So with that being said, I will pass the baton to Abby to introduce herself and get us started. Thank you all for being here.
All right. Thank you, Matt. Yeah, my name is Abby Herrold or Dr. Herrold. I completed my PsyD through the University of Denver last year. And as part of that, did kind of my final residency year at MetroHealth and continue to stay on for my postdoctoral fellowship at MetroHealth. So that is where I am currently. So just wanted to talk with you all about treatment-resistant depression and hopefully give you some more ideas for strategies for support. All right, so as we kind of get into today's presentation, just wanted to talk about depression broadly. So, right, we hear of things like major depressive disorder, but also just depression in a general sense. So some things to look at according to the DSM of symptoms of depression. So low mood, this can be things such as feeling down, depressed, sad, hopeless, discouraged, changes in sleep, increase, decrease, um, anhedonia or lack of pleasure or interest in activities, um, significant weight loss or weight gain, fatigue or loss of energy, psychomotor agitation or retardation, so moving slowly, feelings of worthlessness or guilt, impairment in ability to think or concentrate, and indecisiveness. So it's a very long list of things that can be captured by depression. Um, and I guess I'm curious, kind of trying to make this a little bit more interactive, if people have heard of other things that may not be listed on here associated with depression or things they run into frequently in their practice.
Yeah, feel free to add any to the chat, and I can read them out loud for the group.
Thanks.
Thoughts of suicide, irritability, anger. Those are a few that people have written so far.
Yeah, so I think it's important to touch on or note irritability and anger. I think sometimes that can be one that people don't often think of, but that can often come out with that low mood or feeling down or depressed. I think I hear from some folks that just kind of nobody understands, and that repeated cycle of nobody understanding, I think, can sometimes lead to irritability and anger. Um, all right. Anything else from folks?
Restlessness, and again, anger and frustration.
Yeah, yeah. All right. So, lots of different symptoms, lots of ways that depression can look like. So, I think sometimes when I'm meeting with folks, they can tell me, oh, I'm depressed. And then my follow-up question is, what does that look like for you? What does that mean for you? Because it's one label that we frequently use, but it can look so different for so many different people. All right. So, in order to kind of qualify for a diagnosis of major depressive disorder, somebody has to have five or more of the prior list of symptoms, so these right here, for 2 or more weeks. And then, there's different specifiers for that. So severity, mild, moderate, severe episodes. Has this happened once or has this happened multiple times? So is this recurring depression or a single episode? So typically when we're talking about this idea of kind of quote unquote treatment resistant depression, it is recurring depression. Um, and then it could be with or without psychosis. So sometimes depression can have psychotic features associated with it. Um, so that's kind of the criteria for major depressive disorder. And then for persistent depressive disorder, it is depressed mood more days than not for at least 2 years. So it's kind of that constant depression that doesn't have breaks. Um, and having to have 2 or more symptoms of depression during this time, um, and not being without symptoms for more than 2 months at once. So, um, when you all hear the term treatment resistant depression, what comes to mind for you?
Well, for me, it's when you have tried most of the things that they say that's supposed to help you, from medication to, I don't know, therapy to maybe yoga to whatever, just anything.
Yeah, so kind of, right, you've tried many different things, but it's still there despite trying different things. Yeah, thank you. How about for other folks?
Yeah, just seeing a lot in the comments. Um, Medication's not working, therapy is not working, still struggling to engage in activities. Um, uh, yeah, just a lot of that, a lot of similar comments that multiple interventions are not working, or ECT or TMS, for example.
Yeah. So a lot of times, depression can get labeled as treatment resistant when, right, you've tried multiple interventions or multiple approaches, specifically when you've tried multiple different medications, um, which I think for some folks can feel pretty defeating to have to go and try multiple things. Um, and I think in treatment, it can be a lot of like practicing patience with that. And I also want to comment on this idea of, I put treatment resistant in quotes, just because I think sometimes there can be this idea of with resistance, right, things might not get better or my depression's never going to be treated. And I think it's important to think about this also from kind of a a recovery aspect or model of, right? You might have better days and worse days, but it is possible to see improvement. All right. Any other comments before I move along? All right. So some factors to consider when thinking about depression. So for major depressive disorder, the prevalence being highest in those ages 18 to 29. Typically we see sorry, give me 1 second here. Okay. Typically we see the first diagnosis of depression peak in someone's 20s, or that's kind of the most common, but late in life diagnoses of major depressive disorder are not uncommon. So seeing that for the first time, but typically around age in the 20s is when we are seeing that. Also, women tend to experience depressive symptoms at a rate that is 2 times higher than men. I think of note here in talking about, right, suicide is something that often comes up when talking about depression. Women typically make more attempts of suicide than men do. However, men typically die by suicide at greater rates. So that's something to be aware of. Also, a history of trauma can increase one's risk for depression. So, adverse childhood experiences, or ACEs, which we commonly refer to, can increase one's risk for depression. Also, I think it's important to consider that, right, we don't exist in a silo. So, also external factors can increase our risk for depression. So, low income or financial distress, having limited formal education, racism, other forms of discrimination can also increase one's risk for depression, as well as having family members with major depressive disorder. So, right, age, external stressors, sex, all of these things are factors to consider. Anything else that jumps out for folks?
Not anything pertaining to this slide at this moment.
Awesome. Thanks, Matt. Okay. So earlier I mentioned this idea of, right, so major depressive disorder, and one of the specifiers can be, is this major depressive disorder recurrent or a single episode? So with talking about treatment-resistant depression, thinking of recurrent depression. So according to the DSM, recovery from a depressive disorder may begin within 3 months of onset for 40% of individuals. So in other words, for about 40% of people, recovery happens within 3 months. And for 80% of individuals, recovery happens within 1 year. And I believe recovery is considered 2 or more months without depressive symptoms. So features associated with lower recovery rates include those with more severe symptoms. So who depression is severely impacting daily functioning. People who, when you see the list of depressive symptoms, meet most or nearly all of those symptoms. Those who have depression with psychotic features, so auditory hallucinations, visual hallucinations, things like that. those who also have anxiety, and those with certain personality features or disorders. So something of note here, the risk of recurrence is higher in those with a prior preceding episode of depression. So essentially, if you've had depression once, your risk is higher of having it again. It's also higher in younger individuals and those who have already experienced multiple episodes. So essentially, yeah, depression, if you've had it once, higher likelihood of having it again, which I think is important for us to consider, especially when talking about treatment-resistant depression. But I think that can often sometimes lead to folks feeling hopeless or frustrated, or kind of these feelings that things are never going to get better. Um, does anyone have any thoughts or comments on that idea of kind of once you've had one episode, it's more likely um, to have a recurring episode? All right. There's no thoughts on that one. We'll move on. But essentially going back to this biopsychosocial theory or model of just talking about mental health or talking about disease. So biopsychosocial model, I believe, was originally developed by Engel, who was a psychiatrist. But this considers biological, psychological, and social factors when thinking about health and disease. Um, so thinking of biological factors such as age, gender, genetics, physiological responses or reactions, psychological factors such as one's attitude, emotion, behavior, personality, and then social support. So this could be, or sorry, not just social supports, but social factors in general. So this could be social supports, culture, socioeconomic status, etc. Um, and I found this diagram online. This is not something that is my own, but I like this one because it shows that, right, temperament can kind of be a combination of biological and psychological factors. So maybe you were maybe someone is born with having an increased likelihood of a certain temperament, but then that is further reinforced by different psychological factors. Also talking about trauma being a combination of social factors and psychological factors, and different things of that nature. So the biopsychosocial theory encompasses a lot, in my opinion. Any thoughts, reactions, comments about biopsychosocial theory?
Well, just someone noted that this is a very helpful model for understanding this.
Yeah. Yeah. So, and I think this can also be important when talking about wellness, which we'll get to a little bit more later, but looking at these different factors of, okay, maybe someone is in a really good spot with their psychological factors, but in not a great spot with social factors. So what can we do to also amplify or build up some of those social factors? And also applying that to other areas of kind of the diagram as well. All right. So considering some different theories of depression, there's lots of different theories out there, but just wanted to talk about a few. Um, so there's Beck's cognitive triad theory, which essentially says that depressed people may be more likely to focus on negative thoughts rather than positives, or kind of this cognitive bias. So, um, kind of attributing things to the negative thoughts, having negative beliefs about self or negative schemas, such as like, I am worthless, I'm not lovable, and negative beliefs about ourself, the world, the future. Um, so once again, things like negative beliefs about self, I'm worthless, I'm not capable, the world, um, maybe could be things such as, I don't like anybody, nobody's worth my time, or the future, such as there's no hope that anything's going to get better. Um, and kind of going back to that first point of cognitive bias, such as, right, if something happens, and let's say something, let's just say there's like some road rage and someone in another vehicle is making you angry. And so thinking that they are intentionally trying to do that, then rather than thinking of maybe all the other things that could be leading to that, such as that person's running late, or traffic's really bad, other things of that nature. Um, all right. And then learned helplessness model. So this comes from Seligman, of just people having a learned idea that they are helpless due to perceived lack of control over what happens to them. So to me, this really gets at that idea of agency. So not feeling that people can be an agent of change or an agent of themselves, of what is happening to them. Um, and the diathesis stress model. So this idea that when experiencing a triggering or stressful event, um, so let's say some sort of loss happens, which can then lead to negative emotions such as sadness, anger, irritability, um, which can then lead to some behavioral changes. So maybe a loss happens and then feeling sad, feeling that nobody understands. So then um, we stop talking to people, right? So then isolating ourselves, which typically um, can make us feel worse or reinforce feelings of sadness or feelings of depression. And that's just one example. That can look like many different things. So Beck's cognitive triad, learned helplessness, diathesis stress model. Any questions about these three theories?
Not seeing any questions.
Okay. All right. Well, we will kind of leave these, well, those are there, and I'll use those as kind of a guiding point as we move forward. And we can always come back to them at the end if anyone has questions. Um, so those are some theories on depression. But then going back really quick, all in all, right, this biopsychosocial theory. So whether it's depression or any other sort of mental health condition, kind of considering all of these things, biological factors, psychological factors, social factors. Um, so we talked about um, interventions and treatment-resistant depression often being called that because of having tried multiple interventions and those not being successful. So different types of interventions for depression can look like different medications. So a common one for depressive disorders are selective serotonin reuptake inhibitors. But there are lots of different medications out there. That is not my specialty, so I'm not going to speak too much on that. But then also therapy, so talk therapy, there's cognitive behavioral therapy, which can kind of get at challenging some of those thoughts, acceptance and commitment therapy, dialectical behavioral therapy, interpersonal therapy, group therapies, etc. ECT, which I think someone mentioned before, is typically something that is tried after a couple of different oral medications have not worked. So ECT stands for electroconvulsive therapy, um, which is induced via an electrical current in the brain, and has been shown to help with symptoms of depression. Um, there's also repetitive transcranial magnetic stimulation, um, which is using a magnet to stimulate nerve cells in the brain to improve depressive symptoms. And then also another one is ketamine. So that varies state by state, but it's often used to help with depressive symptoms and is sometimes utilized in combination with oral medication as well. So lots of different treatments out there. For the purpose of this presentation, I'm going to focus a little bit more on some of like the therapy and different cognitive and behavioral strategies, but there are lots of different approaches to treating depression. All right. So when talking about depression, um, social support can be very important. So I'm curious about if you all are willing to share or say or give some sort of indication, how many people on this call have a loved one living with depression that they are supporting or who have tried to support in the past?
I have.
Yep, looks like a lot of folks fall into that category. Seeing tons of it in the comments. Yeah.
Okay, awesome.
Oh, I have a
Yeah.
question. Do we not supposed to speak? We just respond in the chat.
I would recommend just using the chat so we can get through the slides, and we will have more time at the end for Q&A before 1 o'clock.
Okay. I didn't know that. All right, thanks.
That's okay. No worries.
All right, thank you. So it sounds like a lot of people have had that experience. So it can be about, right, kind of encouraging that person or loved one to utilize existing relationships. So family, friends, coworkers, and sometimes I'll talk with folks who don't have a lot of those existing relationships. And sometimes that conversation can then be about, okay, how do we create new relationships? So this could be via community involvement. So getting involved in different organizations, different support groups, right? So NAMI being one great resource that people can utilize to talk about mental health. Religious or spiritual connections. Just kind of finding, okay, if somebody doesn't have social supports, what's something that interests them, and how can they maybe build some new relationships related to those interests? Um, and then there's also professional support. So, doctors, psychiatrists, therapists, counselors, social workers, case managers, um, having some professional supports to reach out to um, when experiencing depressive symptoms. And I think a note on this is just um, sometimes those living with depression, it can be easy to isolate from others. So for loved ones or for caregivers, practicing patience of just, right, even if, for example, you might know that, I'm just going to say a random name, you might know that Sue is going to say no every time you invite her out somewhere, but still making that effort to show Sue that like you care about her, and that you would like to spend time with her. All right. Um, so one strategy when talking about treating depression can be behavioral activation. So this is something I utilize a lot in my work. But kind of just going back to that diathesis stress model of when we're depressed, we kind of stop doing some things that maybe we previously did. So this can look like isolating, like I've talked about, difficulty maintaining hygiene. So it could just be not showering as frequently, not changing clothes, not brushing our teeth, things like that. Difficulty caring for self, which may also relate to hygiene, but could include things like um, difficulty feeding ourselves, difficulty eating, staying in bed frequently. Um, so there's kind of insomnia and hypersomnia. Hypersomnia being getting too much sleep. So sometimes I talk with folks who just they're awake but staying in bed most of the time. Um, Not engaging in activities that somebody previously enjoyed. Um, are also engaging in self-destructive behavior. So behavioral activation in that sense wouldn't necessarily be, okay, how can you engage in this more? But okay, you've engaged in this behavior to cope in the past. What are some other things we can do um, to help with feelings of depression, sadness, etc.? And I think something that's important to know is that behavior often precedes motivation. So a lot of people that I have talked to feel like they need the motivation in order to do something. And while I want to validate that, and I think that can be true, we've also seen that sometimes it's initially taking those first steps um, to do something and then seeing like, okay, I did that thing. Now I feel good. And that can kind of build some momentum. So, um, I think also an important step in this is just acknowledging sometimes it's important to start small. So things can feel very overwhelming. Um, so being clear of kind of what the goal is, setting SMART goals. So specific goals, what is the goal? Is it measurable? So let's say the goal is to shower more. Okay. Measurable. How many times a week? If you're showering once a week now, can we increase that to 2 times a week? Um, Achievable. So something that can be done, realistic, and timely or time specific. So kind of breaking down these goals from not being quite so overwhelming into something more specific, measurable, achievable, realistic, and timely. Um, and I think something that I often try to remind people of is I don't know where I heard this or who told me, but this idea that anything worth doing is worth doing poorly. Um, I think sometimes folks can get stuck in their head about having to do something right or having to do something in a perfect way and just kind of gently challenging that of like, okay, if it's important to you, it's still worth doing poorly. Right. Any questions about behavioral activation or SMART goals?
No, not seeing any.
All right. All right. So I think another thing that can be really important and something I try to incorporate when I work with folks with depression um, is I'll often hear this idea of kind of what's the point? There's not purpose in this. I don't know what my purpose is. I don't know what I'm doing. And I think values can be really important in that work. So identifying someone's values, clarifying them, or regrounding ourselves in our values can be helpful. So sometimes I'll ask folks things such as like, what's meaningful to you? Um, what's meaningful to you? What's your purpose? What are your reasons for living, or what are your motivations for getting better? Um, things like that. And sometimes this is something that people have thought a lot about and they can answer it really easily. And sometimes it's more challenging for folks. So I think in those moments, I'll either ask some of these questions or do some like values clarification exercises. So giving them a list, you can find various ones online of, right, 10, 20 values and saying, okay, what are your top three? What are your top five? And then processing that and why they chose those. And then figuring out, okay, great. We've identified some values. How are you or are you not incorporating that into your daily life? And helping kind of explore and brainstorm with them how they could incorporate those values into their life or what it would mean if they had more of that in their life. So I think this is something that can be kind of recentering or regrounding, or help people get to those kind of bigger questions about purpose or point. All right. And then also thinking about protective factors. Um, so I like to think of this idea of mental health being on a continuum. So as I had kind of alluded to earlier, of just right with depression, there might be some good days, some bad days, but knowing how to cope with the bad days or what makes the good days good days. So some protective factors for depression and helping maybe alleviate some of those depressive symptoms of being social support, as I had talked about earlier, various coping skills. So whether that's challenging negative thoughts, beliefs, physical health. So making sure our physical health is we're doing what we can to manage that, or also getting out, exercising, using that as a coping skill, having this sense of purpose or this connection with values, working to improve self-esteem, which can be done in various different ways. I think this is one I often will encourage clients to reflect on, like affirmations or what is something you want to believe about yourself and coming up with statements for them to repeat those things to themselves. Um, and healthy thinking. So kind of checking some of those negative thought loops. All right. And as I had said, kind of this maintenance idea. So, um, people who have chronic or treatment resistant depression, it can be beneficial to recognize when depressive symptoms are intensifying. So maybe when someone's feeling at a better spot than they have been, or when they're in a space to reflect on these things, thinking about, okay, is there a pattern to their depressive symptoms? What settings, situations, beliefs trigger and increase those symptoms? So if you know that if someone knows that going to school and starting school every year is something that can trigger depressive symptoms, coming up with a plan for that. Checking in with self about sleep. How has sleep been? How has eating and appetite been? Um, how has one's ability to think or focus been? What's been on their mind? Have they been focusing more on positive or negative lately? Any changes in work or daily routine, external factors, changes with loved ones. And I think this last question can be just a good check-in for everyone. But is there anything I haven't been doing lately that I want to do? And then maybe taking that a step further. If so, why? Um, so I think even sometimes encouraging people to write a list of questions down to kind of check in with themselves either every week, every couple of weeks, every month, whatever feels good for them of, okay, where's my mental health at right now? Do I want it to be somewhere else? Is there anything that's currently making it worse? And is there anything I can do to make it better? All right. Um, so for those who are living with depression, right, encouraging you all to reach out for help when you need it. I hear that a lot of people feel like they can be a burden at times, but still reaching out when having those feelings. Utilizing social supports or identifying people you feel comfortable speaking with when you're struggling. Challenging negative self-beliefs. Engaging in activities you enjoy. So whether that's just journaling and reflecting, working out, engaging in your hobbies, listening to music, incorporating things that you enjoy, even if you aren't enjoying them right now, things that you have previously enjoyed to maybe give some time to bring some of that enjoyment back. Setting SMART goals or small and realistic goals for self, connecting with your values, and also considering professional help. So if you aren't in therapy, if you aren't receiving medications, things like that, if you're open to it, then reaching out and even just exploring what your options are. Um, those are kind of some ideas to think about. All right. Ideas for loved ones of someone with depression or caregivers. So, trying to engage individuals in activities they enjoy. So kind of what I had said earlier, even if you know, for example, Sue is going to say no, still asking Sue if she wants to go to the park or if she wants to engage in this activity. Um, Practicing patience, just kind of acknowledging that it can be really tough to do even the small things when people are experiencing depression and granting them and yourself some patience with that. Practicing non-judgmentalness. So just trying to kind of meet someone where they're at or not being quick to judge. Offering assistance in ways that you can. I think sometimes offering assistance with the specific thing, like leading with a specific thing, can be helpful. So sometimes, what do you need help with? That can be a good start. But sometimes even answering that question can be overwhelming for people. So saying, hey, I'm going to cook us dinner tonight, or what if I helped you clean your room or clean your house, that kind of thing. Um, and finally, also taking care of yourself. So, having a loved one who is living with depression can be challenging for ourselves as well. So just taking care of yourself and that and making sure you're checking in on your mental health and giving yourself grace, and using your coping skills. All right. And finally, some ideas for professionals. So when we're working with clients or patients, just utilizing openness, practicing being non-judgmental, as I said, to caregivers as well, practice patience. Considering a combination of techniques. So a lot of times I think in any type of work, it can be meeting someone where they're at. I tend to take somewhat of a humanistic approach to things. So meeting someone where they're at, considering a combination of relationship, cognitive, and behavioral techniques. Um, and reinforcing small wins. I think one of my favorite parts of my jobs is hearing when somebody did something small that small might be small to the rest of the world, but to them was huge, and being able to celebrate those things. So could be you called your friend you haven't talked to in 2 weeks, like I'm so happy, and just celebrating that with them. And reinforcing those behaviors. And then also finally just consulting or collaborating with other professionals as needed. So that could be talking with case managers, that could be talking about medication management, but just collaborating with folks um, when you need to and as your client is open to. So I think with that, that is everything in terms of slides that I have for you all today. Um, but any questions, comments?
Yeah, there was a couple questions earlier that weren't pertaining to your slides, but which I promised folks in the chat we would address before we
Okay.
wrapped up. One question was, can you explain, there was a question, some uncertainty around what does clinical depression refer to, and and how does major depressive disorder or persistent depressive disorder compare or fit in with that language?
Yeah. Um, so I would say maybe clinical depression not having a very exact definition. I guess when I hear the term clinical depression, I'm thinking of depression that impairs someone's life or daily living. So you can be depressed and not necessarily meet a diagnosis of major depressive disorder and or persistent depressive disorder, but still have depression that is showing up on a consistent basis that is interfering with your daily living. Um, so that is kind of what I would refer to, but I think it's one of those things that can mean different things to different people.
Okay, a couple more questions that were in the chat earlier. How is can you explain the differences between the depression that might occur in bipolar type 2 compared to major depressive disorder?
Okay. Um, so with I'm going to answer this very broadly, but generally, bipolar is there's episodes of mania and hypomania, or kind of an elevated mood in combination with episodes of depression. So, in general, we're still talking about this idea of um, depression and a depressive episode. It's just that with bipolar disorders, there are also these fluctuations with kind of this elevated mood as well. Um, but that is something, if you have further questions about, I would encourage you to seek out some more information online, um, and or consult with kind of a professional therapist, doctor about that.
I wanted to also draw to everyone's attention um, I did put a few links to resources in Greater Cleveland. I put information about Strive for Wellness, which provides transcranial magnetic stimulation, TMS. I did put a link to that in the chat, and I also put a link to Stella Luna Counseling and Wellness, which provides ketamine-assisted psychotherapy. Since we talked about those earlier as two options to explore when other methods like conventional psychotherapy and SSRIs, your typical antidepressants, multiple, have not been effective. So I wanted to bring that to everyone's attention. Another question that we had was, what is, can you say a little bit more about acceptance and commitment therapy, ACT therapy, what that consists of?
Yeah. So acceptance and commitment therapy is kind of what is referred to as a type of like third wave behavioral therapy. And so I'm familiar with acceptance and commitment therapy, and it's also not like my primary mode, but in general, this idea of kind of like accepting your mental health and mental well-being where it is. So incorporating some acceptance while also um, emphasizing change or being committed to change. So it's kind of, I always refer to as like this both and, which is an idea that can be drawn from like dialectical behavioral therapy, or DBT, which is also one of those like third wave behaviorism models. But right, your mental health can be struggling, and both accepting that and this idea of acknowledging like what can I do or what not next steps can I take to change things.
Okay, another question I'm seeing here. When looking at next steps for treatment-resistant depression, this is a good question. Is there a general order in which other interventions are tried? For example, ketamine before TMS, TMS before electroconvulsive therapy, or is it just case dependent?
Mm. Yeah, that one I am not quite sure the answer to, as like medications and the right, like non-therapy interventions aren't quite my wheelhouse. I think there are some recommendations out there, but I would encourage you all to seek out some more of that information on your own, and possibly maybe some of those resources that Matt had suggested earlier might have some information about that.
Yeah. Another question, is there anything someone's asking specifically about depression that co-occurs with OCD? Is there anything you can say on that topic?
Depression that co-occurs with OCD.
Yes.
Um, anything more specifically about that? I think right, depression, as I kind of alluded to earlier, depression and anxiety can often lead to like having some more like reoccurrent depression, but I guess I would either need more specifics for the question. So I'm not
Okay.
too sure about that one, but
All right. We'll give them a chance to reply in the chat if they can add more. Um, Another question I see was, so, in circumstances where, a person may be experiencing, um, I mean, I guess the presentation kind of addressed this overall, but
Mhm.
when medication is not effective, when a person continues experiencing suicidal ideation as part of their depression and they're not experiencing any improvement, what are your um, recommendations there on, moving forward in treating or working with depression when, or what are the first steps you might take to address that?
Yeah, so I think first and
Mm.
foremost, like with any safety concerns, right, always being aware of any crisis resources there are. So 988, 911, the emergency department. There's also other things. So being aware of those for when you or somebody else is experiencing a mental health crisis, that you can utilize those. But I also want to acknowledge that suicidal ideation for some people can be kind of this chronic experience. And I think in those cases, it can be kind of working with a therapist, working with a provider, and reflecting upon like, okay, what are the signs of like things are intensifying, things are getting worse? How do you notice those? And then what steps do you take in those moments? So sometimes it can be about just acknowledging that the feelings of depression are there, the suicidal thoughts are there, um, and working with a professional to kind of recognize some of the gray in between and what you can do in those moments.
We just wanted to bring to everyone's attention, I did put the link to the survey for the presentation in the chat. Now, remember, we now have a single unified survey, regardless of whether or not you're attending for CEUs. Please do make sure you fill out the final question on the survey. If you are seeking CEUs, please add your full name, email address, license type, please, and license number, complete number. Thank you. Sometimes I get half a license number or a typo, which obviously makes things difficult for us to follow up on getting your CEUs. So please do provide all that information as requested in the final question of the survey. And I did just put the link in there one more time. Okay. Any other questions? I see. Oh, wait, there was one more here. You spoke of reasons people get depressed. My question is, ruminating on the past, is that a symptom of depression? I would imagine that rumination of negative thoughts, including thoughts of the past, is a very common symptom of depression, correct?
Yeah, I would agree with that.
Yeah.
I have a question about the survey. Is that what is this we're participating in?
This is just the psychoeducation, community education offering. It should be the first one you can check the box for.
Thank you.
Yeah. Just seeing a lot of appreciation in the comments for today's program. Just a few minutes short of 1 o'clock. I guess we'll wrap up now. I'll send the slides to everyone in a follow-up email, and I will also let you know, and we'll also post the recording of this to our YouTube channel as well. All right. Hope everyone has a great day.
All right. Thank you all.